Evening, everyone.
Well, we can start now.
Good evening, everyone. Greetings from RSCP. Respected Dr. Tej K. Kaul, sir, Dr. President Ma'am, Dr. Indrani Ma'am, President-elect Dr. Naveen Malhotra, sir, Editor JOCP Dr. Pradeep Bhatia, sir, Vice President Ma'am, Dr. Anju Garewal Ma'am, Prior RSCP Dr. Sunil Sethi, sir, and all the GC members and other dignitaries on the dais and off the dais. I would like to begin with saying thanks to and for invoking Ma Saraswati's blessings for giving this opportunity to conduct today's webinar. Today's webinar is in continuation with the critical care series and is related to the three important topics related to the chest trauma. We have some very known dignitaries here on the dais for today's webinar, and I would like to call upon Dr. Tej K. Kaul, sir, to say the few words, sir. Dr. Tej K. Kaul, sir, please, sir. Dr. Kaul, sir. I think Dr. Tej K. Kaul, sir, is not here. Dr. Indrani, ma'am. Dr. Naveen, sir, please, sir, few words, sir, from your side, sir, please.
Yeah, good evening all and welcome to RSCP Academic Webinar Series 2022. And today I am very happy that all the three lectures are being delivered by my students. Pooja Vihani, Sudhivya Sharma, and Dipinder, they all are my students. I'm very happy to see their progress, that they are now joining and as an active role as faculty in different scientific programs. Best wishes to all of you for such a nice topic on chest trauma, and they will be ably guided by the chairpersons who are teachers par excellence on their own. So thank you all for joining today.
We have with us, thank you very much, sir. Thank you very much for your kind words, sir. We have with us our President, Honorable Dr. Indrani ma'am. Welcome back, ma'am. We have been continuously watching you on the Facebook, and few words from your side, ma'am, please.
Thank you very much. It's really nice to get back.
Hello.
Wonderful topic on trauma, and I'm actually looking forward to hear this this entire webinar. So good luck, and we can go with the webinar.
First topic of our webinar series is chest trauma, hemothorax, pneumothorax, and flail chest. And the chairpersons for the first session is Dr. Pradeep Bhatia and Dr. Manoj Kamal, sir. Dr. Pradeep Bhatia, sir, he doesn't need any introduction. He is professor and head of Department of Anesthesia and Critical Care in Jodhpur. Sir is editor, JOCP, and his area of interest is critical care, airway management, and pediatric anesthesia. Dr. Manoj Kamal, he is additional professor, Department of Anesthesia and Critical Care, AIIMS Jodhpur. Sir's area of interest is cardiac anesthesia, pain and palliative medicine, renal transplant, anesthesia. Over to you, Dr. Pradeep Bhatia, sir.
Thank you, Doctor. Thank you, Dr. Vishal. It's a pleasure to be here this evening for some interesting topics, and I'll be chairing a session which is going to be the lecture is going to be delivered by Dr. Pooja. She was with us for 4 years at AIIMS Jodhpur, and we have very special affection for Dr. Pooja, and she'll be speaking on chest trauma. Dr. Pooja.
Dr. Pooja, are you there? Can you hear me? Dr. Pooja, over to you, please.
Okay. Can you start sharing my screen, Dr. Vishal?
Sure, please.
Yes. Yes. Good evening, everyone. And I'm Dr. Pooja from SN Medical College, Jodhpur, as an assistant professor. Thank you so much, Dr. Vishal, Indrani ma'am, Naveen Malhotra sir, for giving me this opportunity to speak on this topic and on this platform. And thank you very much, Bhatia sir and Manoj Kumar sir, to spare their time to chair this session. As we all know, that trauma is the third leading cause of death in all age group after cardiovascular disease and cancer. But it is the most common cause of death and mortality in first few decades of life. Body and most of the patients of trauma, up to 25% of the trauma victims die because of thoracic injuries and its complication. So we can see the gravity of trauma, which will lead into mortality and morbidity to the patients. All right. So up to 20-25% of polytrauma victims may suffer mortality because of chest wall trauma. And the chest wall trauma can occur because of penetrating chest wall injury and the blunt trauma chest. The penetrating chest wall injury will result in the disruption of the tissue integrity and underlying structures can be damaged. And in the blunt trauma chest, the underlying tissue and skin is intact, but they can be damaged to the underlying structures. You can see there can be a variety of presentation. There can be thoracic injuries and extrathoracic injuries because of blunt trauma chest. In the thoracic injuries, up to 66% of the patients have rib fractures, but the magnitude of frail chest is up to 23 to 25%. Pneumothorax, these are the conditions which are associated with the high mortality because of chest trauma. And they can be extrathoracic injuries might be associated. You can see the skull fracture, cerebral concussion, facial fractures may be associated. And so a multidisciplinary approach is very important if you are dealing with a patient of polytrauma. All right. So the best example, what are the mechanism of the blunt trauma chest? It can happen because of the on the thorax, because of thorax compression, which is mainly because of compression injuries, and because of increasing chances of motor vehicle accidents nowadays going on. The acceleration and deceleration injuries and steering wheel injuries are also very common, and blast injuries. This can happen. All right. And because of these high-speed injuries, any part of the thorax can be damaged. What are the deadly dozen of the chest trauma? There are some life-threatening conditions which are identified by the Injury Society, and they have identified 6 life-threatening conditions which have to be addressed immediately. And out of these, airway obstruction, tension pneumothorax, open pneumothorax, massive pneumothorax, flare chest, and pericardial tamponade. These are the conditions which need to be immediately investigated and treated because these are potentially life-threatening conditions. Along with all these comorbidities, pulmonary contusion, tracheobronchial injuries, diaphragmatic injury, myocardial injury, esophageal injuries are also very potentially life-threatening and should be investigated immediately and treated immediately. Blunt trauma affects very differentially between the pediatric and geriatric population. In the pediatric population, there is a pliable chest wall, so the chances of injury is there, but the chest wall remains intact and underlying tissue can be damaged. But in the geriatric population, because of the osteoporotic changes of the rib cage, there can be mild injury which will result in the severe tissue trauma. So these are the population you have to be very cautious while dealing with the chest trauma victim. Now, what are the mortality predictor after blunt trauma chest? This is the article published in Injury Society, and they have shown some risk factors that predict mortality after blunt trauma chest. Out of this, increasing age, multiple risk fractures, presence of pre-existing cardiac pulmonary disease, and development of pneumonia post-injury. Along with that, low GCS score in chest trauma are highly predictive of mortality, and these are the patients which need to be addressed immediately. What are the clinical examination and clinical findings? Nowadays, our teaching is going towards residents and non-resident and postgraduate students are not focusing on the history and examination. But see, history and examination is the foremost and important part of dealing with a trauma victim because it can give you very important information. So a holistic approach is very important. You have the patient from the tip to toe, and it will not only help in diagnosis, but also help in the emerging modalities what we are going to go for that particular patient. So what will you see? You can see the cyanosis of fingers, lips, and face. The patient may be in the respiratory distress, may having dyspnea, tachypnea, bradynia. There can be multiple contusion, lacerations, perforations. If the patient is developing signs of hemopsis and signs of shock, the vital signs examination is very important, because the patient is having shock. There can be underlying pneumothorax and tension pneumothorax and hemothorax. This is very important. Simultaneously, any signs of tracheal deviation, paradoxical movement of chest wall, distended jugular veins, absent or decreased breath sounds, and failure of chest expansion, normal inspiration. These are the clinical findings which will alarm you that underlying some important life-threatening condition might be happening in the patient that need to be addressed. Coming to other clinical findings, important vital signs are one of the most important indicator of blunt thoracic trauma, and presence of tachycardia and hypotension are very, very valuable. Ecchymosis may be there, presence of back striate, that is the distended neck veins, hypotension, and muffled heart sound might suggest underlying cardiac tamponade that need to, because the life-threatening condition need to be addressed as soon as possible. Presence of palpitation, subcutaneous emphysema, and tenderness might suggest underlying pneumothorax. So that again need to be decompressed as soon as possible. So history and physical examination are integral part of approach to these patients. It should be noted that each and every trauma victim, the signs and symptoms may be non-specific to be severe symptoms. Accordingly, you will order some imaging modalities. What imaging modality? The first line of imaging modality is chest X-ray, which will give you information regarding the presence and absence of rift fracture, presence and absence of pneumothorax, hemothorax, tamponade, it may suggest. But if there is some concealed injury, then have to go for the CT scan, which will accurately diagnose the essence and nature of the injury. But the limitation being patient transportation to the CT room. This is a major limitation. Now, how will go and assess and manage a patient with a thoracic injury? All the stress trauma victim or trauma victim will undergo a management and assessment as per ATLS protocol. And until unless it is proven, you will suspect the patient is having some C-spine injury and instability. So you will treat those patients according to line of A, B, C, D, E, the primary survey and secondary survey. And keep in mind, most of the 90% of chest trauma victims will require just conservative management, and only 10% of the patients who will require mechanical ventilation and further support. So go and see according to the airway, breathing, circulation, disability, and exposure. And for the conservative management, you will see appropriate airway assessment, oxygen therapy, tube thoracostomy if it is required, volume resuscitation if undergoing patient is having hypovolemic shock, pulmonary toileting and all. This is the thing, if you're going with the airway management, for the airway management, C-spine immobilization, and it's very, very important. And accordingly, indication for some indications, the patient is having respiratory distress, you have to go for the tracheal intubation and mechanical ventilation. During the primary survey, if the patient is having no air hunger, patient is able to speak easily and can describe what happened in the last few events, then you can see the patient is having normal airway and you can go for the further management. And you can see if the patient is hemodynamically stable, then you can go with the chest X-ray, imaging modality and further management. But if the patient is having is hemodynamically unstable, you just go with a fast scan as soon as possible and can advise a chest X-ray. But if the clinical findings are suggestive of some underlying life-threatening condition, go for emergency department thoracotomy, needle thoracostomy, tube thoracostomy, pericardial centesis, etc. before going for the further management. Now we can go with the next topic, that is these are the emergency equipment which should be available for trauma resuscitation. All the oxygen supplementation device, ventilator device, intubation kit, suction, important monitors, emergency drugs should be available when you are dealing with a trauma victim. Now coming to the next part, next topic, that is a flare chest. What is a flare chest actually? And it's a very important condition, and it's also a probable life-threatening condition. If the patient is complaining of flare chest, isolated rift fracture is not very life-threatening, but yes, if the flare chest is there, patient needs to be treated immediately. What is flare chest? This is a condition in which 3 or more consecutive ribs are broken at 2 or more points of the thoracic cage. So you see, this part of the ribs, this part of the rib cage become isolated from the rest of the rib, from the thoracic cage, and it becomes free and it moves paradoxically with each inspiration and expiration. With inspiration, it will move inward. With expiration, it will move outward. So it will result in the trauma to the underlying chest tissue also. And it loses its continuity with the rest of the thoracic cavity. Now the first two ribs, next, the first two ribs are in continuation with the, this is a report, this is a report published in some Turkish journal, and they have shown their experience of 4,205 patients with the chest trauma, attended experience. And what has this shown? The mortality after the flare chest, the mortality after chest injuries is approximately 4 to 5%. So you can see this is a good movement, and we have to treat it as early as possible. Next. Incidence of chest wall injuries such as ribs, sternum are very high. And if the patient is having increasing age, presence of multiple comorbidities, and high injury severity score, these are the conditions which need to be addressed immediately. This is the pathophysiology of the flare chest. This segment of the flare segment, it moves paradoxically inwards during inspiration and outwards during expiration. So it will result in pulmonary contusion and pneumothorax in successive time, and also is a very painful condition. So appropriate pain management is very important if you're dealing with a patient with a flare chest. Same thing, inspiration, it will move inward. So these are the pathophysiology of the flare chest. There will be hypoventilation due to pain, impaired gas sections due to parenchymal damage, and alteration of breathing mechanics will be there with the flare chest. So you can see the first two ribs are actually strongly attached to the musculoskeletal system, and they are actually difficult to get damaged. But if they are injured, there will be high chances of mortality because of underlying mediastinal structure. But mostly rib 3 to rib 8 are mostly injured and can be diagnosed with proper history and physical examination. If you look, there can be underlying pneumothorax as well. What are the imaging modality? The primary line of imaging is the chest X-ray. You can see the number of rib fracture and what are the size of the rib fracture. But CT scan can show, is highly accurate for showing the location as well as the number of rib fracture. But it is not always required if you are going, if there is very high severity of injury, and if you are planning surgical fixation of flare chest, then only CT is advised. Otherwise, you can go with the chest X-ray and diagnose it. The management will constitute pain control, which will be discussed in our last session, management of the pulmonary dysfunction, and surgical fixation. What are the indications of intubation and mechanical ventilation? If the patient, because of flare, is developing respiratory failure, then only you will require mechanical ventilation. Otherwise, patient can be managed conservatively with appropriate pain management. Now coming to what are the indications of surgical fixation of rib fracture? If the patient is unable to be weaned off from the ventilator and having persistent pain, there is severe chest wall instability, and there is progressive decline in the pulmonary function, then you have to go for rib fracture surgical fixation, and it should be done as early as within 72 hours from the injury. Now, what are the perioperative concerns if you are planning for the surgical fixation? Airway management, I again already told, if until unless proven, you should consider having a C-spine injury of a chest trauma victim. So airway management with a C-spine stabilization. Mostly if you are fixing the chest wall, then patient can be timely extubated because patient will get relief of pain, as well as there is fixation of the chest wall, so timely extubation can be done. Appropriate pain control is very, very important. Thoracostomy tube management, usually surgeons don't put a thoracostomy tube, but yes, if they put the thoracostomy tube and the output is less than 200 ml in past 24 hours, then you can remove it as early as possible. And lastly, very important is disability management and chronic pain management is an important part for if you're dealing with a flare chest victim. Next topic of today's talk is this pneumothorax and hemothorax. What is pneumothorax? Pneumothorax is the presence of air between the pleural and visceral pleura and parietal pleura. And normal open pneumothorax is not a problem, but if it is causing a one valve check mechanism, so the air will enter in the pleural cavity with each inspiration, but it cannot escape out. So there will be accumulation of air in the pleural cavity, which will be causing compression of the mediastinal structure as well as the lungs, causing hypoxia as well as tension shock. That's the condition which need to be addressed immediately. Otherwise, normal pneumothorax is not causing major problem. And the traumatic pneumothorax is the most common cause of this non-spontaneous pneumothorax. Iatrogenic pneumothorax can occur because of subclavian vein catheterization or various kind of block or echocentesis kind of processes. The mechanism of pneumothorax, it usually occurs because of alveolar rupture due to increased alveolar pressure, pepper bag effect, acceleration, deceleration injuries, or rib fracture, that is flare chest damaging the pleura. And it happens in almost 40 to 50% of the patients with the chest trauma. So, and it's important life-threatening condition. Tension pneumothorax is actually life-threatening condition. Next is a simple pneumothorax. This is not a very big problem. It's a presence of air between the parietal and visceral pleura. It occurs because of lung laceration with the air leakage. So it will just result in ventilation perfusion mismatch, but yes, simple pneumothorax can be converted to tension pneumothorax, so it should be treated as early as possible. Next is open pneumothorax. It's a large defect in chest wall, and because of equilibration of intrathoracic and atmospheric pressure. And if defect is more than 2/3 of the tracheal diameter, air preferential passes through the rib, and ventilation is hampered and can result in respiratory failure. And if because of development of the one valve check mechanism, there will be development of the tension pneumothorax, and this accumulated air in the pleural cavity will compress the lung and it will shift the mediastinum opposite side, and there will be resulting shock. And listen, if we are having chest pain, tachycardia, hypotension, tracheal deviation, distended neck vein, and all these clinical findings are highly suspicious of tension pneumothorax, don't go ahead for the radiological confirmation and go for the needle thoracostomy. The primary line of modality of imaging is chest X-ray, but nowadays people are going toward ultrasound confirmation of tension pneumothorax, which will be discussed in the next session. And in the emergency as well in the ICU, you can immediately go for needle thoracocentesis after confirmation with the USG finding. Yes, CT is important to diagnose tension concealed pneumothorax basically. These are some images in which there is a decreased chest movement of this side of the chest, and there is paradoxical movement the patient is having. In this image, you can see the patient is a subcutaneous emphysema. In this, there is massive pneumothorax on the left side of the thorax. And this is bilateral pneumothorax along with the mediastinal widening because of concomitant aortic tear. So the diagnosis is basically made on the decreased breath sound on affected side, resonant note and percussion, chest X-ray, ultrasound will help in the diagnosis. Occult, for the occult pneumothorax, you have to go for the CT scan. The chest tube insertion is mandatory if the patient is undergoing some surgery or mechanical ventilation. Chest tube is otherwise, for emergency procedure, go with the needle thoracostomy from the 2nd to 5th intercostal space. Needle decompression is actually an emergency treatment procedure for tension pneumothorax, in which large wide bore needle is inserted between 2nd intercostal space. And it will convert the tension pneumothorax to simple pneumothorax. But ultimately, you have to put a chest tube. And if the lung is not expanding fully after tube thoracotomy, then an ongoing air leak is there. You have to evaluate it bronchoscopically or by VATS procedure to exclude any airway injury. Now coming to the massive pneumothorax. What is massive pneumothorax? It is the rapid accumulation of more than 1.5 liters of blood in the chest wall cavity. And it commonly occurs because of penetrating trauma, because of injury to the major systemic and hilar vessels present here. And in the one pneumothorax can accommodate, as much as 50 to 60% of entire blood volume. So there will be two simultaneous things happening with the pneumothorax. Because of the presence of blood, ongoing blood loss, there will be hypovolemic shock, and because of compression of the lung tissue, there will be hypoxia, and because of shifting of the mediastinum, there will be this tension shock will also be developing. So you have to be treating both these conditions simultaneously. That is ongoing resuscitation along with the management of this hemothorax. So with that, you have to again go for tube thoracostomy, put a chest drain along with simultaneous crystalloid, colloid, and blood resuscitation. Clinical diagnosis, chest X-ray, UAG, and CT will help in the confirmation of diagnosis. Put a large ball IV cannula. Start with the crystalloid resuscitation, then blood transfusion as early as possible. Put a chest tube at the level of nipple just into the mid-axillary line. Arrange for transfusion. Most cases of pneumothorax can be adequately treated with the tube thoracotomy and restoration of the circulatory blood volume. So thoracotomy will depend on the physiological status, no doubt. And they will be if the patient is having persistent need of transfusion, go for emergent thoracotomy and sealing of all the blood vessels, and surgical suture will be required at that time. So management of pneumothorax, tube thoracostomy, it will be required to clear the pleural space as much as possible. Sometimes VATS or thoracotomy is needed to drain inadequate drainage and retain pneumothorax. They can be retained hemothorax if there is inability to perform early tube thoracostomy, there is insufficient drainage, or iatrogenic effusion due to intervention. So a retained clot in the pleural space as a result of hemothorax is the primary predisposing factor for post-traumatic emphysema. So what is the take-home message? Every trauma victim, especially chest trauma victim, go with a holistic approach, diagnose the patient and examine the patient from tip to toe, because they can be life-threatening blunt chest wall injuries, which can occur from the soft tissues to the underlying vital structure that require urgent intervention. Following these injuries, patient may present with simple dyspnea or even respiratory arrest. And 90% can be treated with simple measures such as airway support, oxygen support, volume support, and tube thoracostomy. Adequate pain control is very, very important, which will be discussed later. And with definitive diagnosis, the morbidity and mortality can be significantly reduced just by simple measures. Thank you. Thank you so much.
Over to Dr. Bhatia, sir. And
thank you, Dr. Pooja. Thank you, Dr. Pooja, for the wonderful presentation.
Yes, sir.
Just a question from my side to you for the benefit of all the audience and particularly PGs. If the patient of a flail chest is in your ICU, would you like the surgeon to operate upon and fix the chest wall by some plating wiring? Would you like to advise the surgeon, and what will be the protocol in such cases?
Yes, I have discussed not only all the cases of flail chest will require surgical fixation. Only 10% of the patient will require surgical fixation. Otherwise, most of the cases can be managed conservatively just by giving oxygen support, appropriate pain control, and sometimes maybe the simple NIV measures. The appropriate pain control is very, very important in flail chest. You can put a thoracic epidural, or people are also going with away from the neuraxial block towards ESP, MTP block also. So if the patient is treated appropriately with the pain control, and patient is going with the incentive spirometry, and that rib cage and that the flail segment is not causing pulmonary contusion and pneumothorax kind of symptoms, patient can be managed conservatively. But yes, if the patient is having respiratory failure, then you have to go for the surgical fixation at that time.
So yes, Dr. Pooja. Most of the time, if the flail segment is a large segment and is causing respiratory problem, very, very often it is associated with pulmonary contusion, which very often becomes a nidus for infection as well. So even if you put the patient on ventilator and initially lungs are compliant, but later on they may have lots of problems like ARDS and all sorts of problems, and the chest wall will not become stabilized until at least 3 weeks. So a prolonged ventilation might be required, and all the problems of prolonged ventilation can be there, including VAP and other kinds of infections. So it's a tricky situation. Yes, otherwise patients are mostly recoverable, and if we can prevent hospital-acquired infection. Any questions from the audience, Doc?
I think only if the segments are more than 3, and if it is bilateral. So these are the conditions where, as you said, patients can go into respiratory failure, because of the segment and the what do you call paradoxical breathing, and patients because of pain, they don't have proper inspiration, and all those reasons could add to the respiratory failure. But usually what traditionally what is being taught is, if the segment is more than three segment flail, uh, or if it is three segment flail, especially if it is bilateral, then then it needs active intervention. This is not surgical intervention. What I meant to say is, as she said, pain relief and things like that. So
Yeah,
surgical
actually,
intervention will depend upon what the exact trauma is. So for
so surgery.
example, I'm reminded of Princess Diana. She needed a surgical intervention because she had a tear in the pulmonary vein. So, surgical intervention basically depends upon, depends upon what the problem is following the chest trauma. But just for a flail chest, I think if the segments are more than three, I think you need to actively give pain relief, support the chests, and go ahead with the treatment like that.
I agree with you, ma'am. Surgical intervention generally is done whenever the indications are more than one. I mean, for any other intervention patient is being operated upon, only then the chest fixation can be thought of. Otherwise, just for fail chest, it is generally not indicated. So, Dr. Manoj, do you have some comments, Dr. Manoj?
Yes, sir. Nowadays, surgery for thoracic trauma is very infrequently performed, because nowadays strapping is most common procedure which is performed for the flail chest. And pain management is also very important things to prevent the postoperative complication or lung contusion, or patient may have tolerate in physiotherapy, because that is very important thing to prevent the pulmonary complication. So pain management, I think it is very important for the chest injury, or early diagnosis and appropriate management is very important, because many a times chest trauma or blunt trauma initially didn't have any symptom, and we have to exclude cervical and abdominal trauma also during the surveillance of the chest trauma.
Absolutely.
So there is no question seems in the chat box. So
thank you very much, sir. It was indeed a very good discussion. Thank you very much, Dr. Pooja. Thank you very much, Dr. Pradeep Bhatia, sir. Thank you, Dr. Manoj Kumar. Our next topic is extended focused assessment with sonography in trauma, and it would be by Dr. Sudhivya Sharma, and the session would be chaired by Dr. Shweta Pokle from Cambridge and Dr. Naveen Paliwal from Jodhpur. Dr. Shweta Pokle.
Yeah, hi.
Hello, ma'am.
Hello, hi. Can you hear me?
Just hold on, please.
Sure.
Dr. Shweta Pokle is from Cambridge. She is from Addenbrook's Neurocritical Care ICU. Madam is a fellow in regional anesthesia, fellow in trauma anesthesia, and fellow in neuroscience and trauma critical care. Dr. Naveen Paliwal, he's associate professor, Department of Anesthesia and Critical Care, SNMC Jodhpur, and his area of interest is critical care and regional anesthesia. Over to you, Dr. Shweta.
I think Sudhivya would be the one conducting the talk.
Please introduce and welcome the speaker.
Yeah. Sudhivya, sorry, am I supposed to?
Yes, ma'am. Please, ma'am. Please go ahead.
Yeah, so essentially, I think the talk right now is about ultrasound, the use of eFast and ultrasound. And it is going to be conducted by Sudhivya, who also happens to be a very good friend of mine, who is right now working as a consultant at Tata Medical Memorial Hospital at Mumbai. And she is her, specialty though is in pediatric anesthesia, but she's been extensively working in critical care as well. So over to you, Sudhivya.
Thank you. Thank you so much, Shweta.
Yeah.
I'm just sharing my
screen. Ma'am.
Am I audible? Can you see my screen?
Yes, ma'am. Yes, ma'am. You are very much audible. Please go ahead, ma'am.
Thank you so much. Thank you so much, Dr. Vishal, Indrani ma'am, and Naveen sir. Greetings from Tata Memorial Hospital. This is ultrasound is the new armamentarium of every intensivist, and we'll be discussing EFAST and role of lung and heart ultrasound in trauma management. So I would try to cover the definition, the indications and contraindications, pros and cons with respect to CT, very clinical applications of this, components, rationale, and outcomes. So EFAST, FAST has been a part of the ATLS program ever since, and extended FAST is extended focused assessment with sonography in trauma. It's a bedside protocol which is designed to detect peritoneal fluid, pericardial fluid, pneumothorax, hemothorax in a trauma patient. So the extended, it stands for the anterior chest views, the chest ultrasound that we do, in addition to the 4 components of FAST. As it has been discussed very well by my colleague Pooja, the indications of FAST, we need to understand where its indications as well as its limitations. So because it's bedside, it's point of care, we can repeat it. Evaluation of injury, hypotension, and shock of unknown etiology in a trauma patient should be done immediately. Any unexplained, a concealed shock, concealed reason for hemorrhage, unexplained hypertension, rupture of ectopic pregnancy, immediately can be picked up by EFAST, which is an examination you can complete in 5 minutes. This, we have to understand when to do this, because if it's an unstable patient, you should go ahead with FAST and take a decision for triaging or the definitive treatment. If the patient is stable, and you should still do FAST, but again, we need to think if the patient is shiftable, CT will remain the gold standard in trauma. The contraindications will be wherever we feel that ultrasonography will delay the definitive treatment or surgery. There we should not waste our time with EFAST. So it is a very sensitive test, but it is not specific. So there are so many false negatives. If it is positive, it gives you a lot of information. But if it is negative, we need to understand that it doesn't mean that the findings are negative. We may have to confirm it with other tools. So FAST scanning, it has a sensitivity in the range of 90%. And specificity, some studies, they say it's 95%, but in certain modalities, we will see the type of injuries where the sensitivity can be even as low, specificity can be as low as 48%. So we have to understand that it's a very sensitive evaluation. The cons are that for the solid organs, it may not be that sensitive. Certain injuries like mesenteric vascular injuries, solid organ injuries, a hollow viscous injury, diaphragmatic injury, it may not result in free intraperitoneal fluid, and so it may not be detected. There are so many false negatives. It could be obesity, a poor window, subcutaneous emphysema. There could be false positives, any pre-existing fluid, any fat pads, descending aorta, cysts. So we need to be aware of its limitations. CT is the standard modality. Let's not forget that. But when there's a patient in front of me and I cannot transfer the patient, it is time consuming, expensive, radiation exposure, mainly if the patient is too unstable to transfer, then this EFAST becomes handy. But however, the presence of clinical injuries that require emergent operative management in unstable patients like lateralizing signs, you can start with the exam and bypass the CT scan. As Pooja mentioned, primary and secondary survey, these are hallmarks of ATLS algorithms. So in primary survey, there are certain injuries that we have to pick up. There's any obstruction, there is tracheobronchial tree injury, tension pneumothorax, open pneumothorax, hemothorax, cardiac tamponade. In secondary survey, we can pick up relatively less severe things, pneumothorax, hemothorax, flail chest, contusions, blunt injuries, diaphragmatic injuries. So we need to keep in mind what we are looking for. When we talk about the components, we talk about 4 components, which are part of the FAST, and the extended will be your thoracic views. Pericardial, perihepatic, perisplenic, pelvic, and thoracic. So very briefly, I will be covering these components. We use a low frequency, 3.5 to 5 megahertz transducer. Any probe which is low frequency has deeper penetration so that we can see a larger window. Patient is supine. We stand next to the patient. Slightly Trendelenburg helps because it helps in collection of the peritoneal fluid in the upper quadrants. Let me start with pericardial sac. So in a thoracic trauma, we are dealing with causes with very vital organs such as lungs and heart. Pericardial sac is evaluated first because if there's a penetrating trauma, we are looking for any rupture, pericardial tamponade, cardiac tamponade. So in the subxiphoid position, as shown in the diagram, we are going to observe the one side of the tip of the liver, the left edge, the right ventricle, left ventricle, and see the pericardial effusion. So if you see this, this picture, you will see that pericardial sac, if there is a blunt injury, this will be filled with blood and it may actually compromise the filling of heart, which we call cardiac tamponade. So if you see that there is a huge pericardial, there is initially when there is bleeding, the echogenicity, it looks like fluid because the blood has not clotted, and this is what is the appearance of a cardiac tamponade. So the first thing which is life-threatening we pick up is pericardial effusion, big effusion, cardiac tamponade. Second is the perihepatic view. So we go to the right upper quadrant and we visualize the hepatorenal recess. So you see liver at one edge, you see the kidney on the other, and usually there is no fluid. If you see free fluid, where has the fluid come from? And this is a positive finding. You see the right paracolic gutters, the hepatodiaphragmatic area, and the caudal edge of the liver lobe as well. So if you can see, there is a small rim of fluid which is collecting between the liver which looks like a tissue. And if you can see this is the kidney with all the calyces, and this is the location of the probe. So this is the normal appearance. The kidney looks fine. The livers, all the veins are well intact. In case there is, if you see that there is a rim of fluid here, this is your liver, this is the kidney, there's a small rim which is collecting. Let's see if it is more severe than that. So there is a bigger collection. So this is the Morrison's pouch. This is hepatorenal recess. In the perisplenic, so if there is fluid collected in the right upper quadrant, it could be because of any liver rupture, any injury in that area. If it is any fluid collection in the left upper quadrant, it could be a splenic injury. So again, we are going to put our probe in the posterior axillary line, 9/10 intercostal space, and look at the splenorenal recess. We will also examine the subphrenic areas, the left paracolic gutter and the lower hemothorax. So to detect the splenic injury. So if you see there is again a rim of fluid here, this is your spleen, this is the spleen. Sorry, this is the spleen and this is the kidney, and there is fluid collection. So this spleen and kidney, it looks quite okay. There's a small rim of fluid which is starting to collect. And we see a bigger fluid pocket here. So the best thing about FAST is that it is something you can repeat. So you can see the progress of your patient gradually after the management that has been undertaken. Moving on to the pelvic view. So your four main important views are your pericardial, hepatic, splenic, pelvic. In the suprapubic, again, you place the transducer superior to the pubic and evaluate the fluid.
Very nice, lavish party. One of the wives started off,
so we are talking about rectovesical pouch in males, that is between the rectum and the bladder. In females, it could be rectouterine and the vesicouterine pouches. So again, there will be fluid. This is a small rim of fluid that is seen. So this is the rim of fluid seen in the male, which is a This is the rectovesical pouch. And here, if you see a very small one, this is your bladder, this is the uterus. So it was uretrovesical pouch. Coming to our main topic, thoracic view. So my aim here is that if there is a trauma patient with my clinical history, if I can pick up pneumothorax, hemothorax, and pericardial cardiac tamponade. These are the three very life-threatening and very common pathologies that can happen. So EFAST, which is now the standard of care, you need to do just 2 anterior thoracic views in EFAST. But as an intensivist, I would recommend that even the lateral windows are recommended, right? And we would just mention blue and a false protocol as well. So if you see these, normally you will see the ribs. In between, you will see the pleural line and you will see the lung slide. So these are the ribs with the acoustic shadow behind. You have the pleural line, where the lung slide will be seen, right? And let's see what are the positive findings. So this is a normal video of the lung slide. If you can see, so this is absolutely normal. Here, again, the lung slide is seen in a different window. You can see the ribs on the both sides with acoustic shadows, and we have a clean, good lung slide. Now, if I need to know what I have to look for. So if my chest trauma is in the upper part, it could be serious. I should be able to pick up serious trauma. It could be a ruptured bronchus. It could be something for very, very vital structures. Immediately, they may need intervention. If I'm talking about 4 to 9, then in that side, there may be pneumothorax. There could be a contusion. If I'm looking at the lower lips, I'm very worried about my liver and the spleen. So I need to pick these up. In continuation with the lung ultrasound, air is not a good conductor, and we use all the artifacts to give us information about the lung. And it is very informative. So if you see A lines are equidistant. These are basically reverberation and mirror images of the surface line. So this is equidistant lines, which is absolutely normal. These are B lines. B lines, if it is less than 3, it's fine. So these are from the pleural line. These are these comic tail shadows, which are mainly due to the alveolar edema and the interstitial edema. If they're more than 3, these are B lines. Then the third is consolidation, which looks like tissue. So it looks like liver kind of sonogram. And this is due to consolidation. So as Pooja mentioned about pneumothorax, so pneumothorax is that the air has come in between your parietal and visceral pleura. Because of that, we all are doing negative inspiration, the lung collapses. Lung collapses, one thing is just an open pneumothorax or a simple pneumothorax, where the lung collapses, so the patient is tachypnic and breathless. The other could be tension pneumothorax, in which the air which is entering, it is increasing with every breath, and there is a mediastinal shift. So, which could be life-threatening and needs very urgent evacuation. Pneumothorax, these 4 things: absence of lung sliding, there is no B lines, no lung pulse, and presence of lung point. It is almost 100% diagnostic of pneumothorax. So there is no lung slide. And if I put an M mode, normally there will be a seashore sign. But in cases of pneumothorax, it will look like a barcode. And if you can identify a point where there is a seashore and a barcode sign, that is the lung point. That means at that particular point, your pleura is starting to separate. Absence of lung sliding, your barcode sign, absence of lung pulse, and if you can find a lung point. The challenge with EFAST or lung ultrasound is that presence of lung sliding excludes pneumothorax. But if it is absent, then we still need to see that whether it could be an atelectasis, it could be adhesions, it could be a 1 lung intubation, diaphragmatic paralysis, subpleural blebs, hyperinflated lungs. There could be other causes, but if it is present, it excludes pneumothorax. Talking about hemothorax, as I said that initially when the patient bleeds, the blood looks like fluid, and later it clots and the echogenicities can be seen. with your ultrasound, you'll be able to evaluate. Like here, if we see that there's a small rim of fluid in between the liver and the lung, it increases further, it becomes more, and this looks like a massive pleural effusion. Whether it's a hemothorax or it is just effusion, there is no way to find out other than when we tap it. So we will be able to quantify it and identify it. Consolidation. So there may be, like consolidation, it could be a subpleural or it could be tissue-like. This usually is not there in the acute settings, but we should be able to demonstrate it because sometimes contusion also looks like consolidation. We are talking about EFAST. And as I said, for us, it's very important to use a test in the right way. So if there is an unstable patient, we should immediately do EFAST when we know we are not able to transfer the patient, and there will be information which will be useful in the management or triaging of the patient. If the patient is stable and my FAST is negative, I should definitely do CT because there could be certain solid organ injuries, some concealed findings, which my FAST may not be able to pick it up. So the sensitivity, we have seen various studies that for pneumothorax, it's very good. For hemothorax, relatively lower. And if you have to detect lung contusion, then its sensitivity further goes down. So the most effective use of FAST is rapid triage of hemodynamically unstable trauma patients to definitive intervention, which leads to reduced time to appropriate intervention, shortened hospital stays, and lower costs. There are various literature on the same. Some studies, there's a recent consensus statement for EFAST in children, which brings it equivocal to CT. There is no added advantage. Some of them, they shed light upon that it should not delay your definitive treatment, right? So there are so many literature, but it is a very, very useful modality because positive findings definitely help us. A word about blue protocol and false protocol. So blue protocol with the imaging of, with the ultrasound of, which tells us about the A profile or the B profile or the C profile, they're in intensive care, even in the non-traumatic patients, we will be able to identify not only pneumothorax, hemothorax, but also pneumonia, pulmonary edema, pulmonary embolism. False protocol, where the same subxiphoid position, where if the patient comes with shock and we don't know what the reason for shock, immediately if you put a subxiphoid ultrasound probe and you see the heart cardiac contractility, you will be able, if there's a cardiac tamponade, if the RV is dilated, you know it is an obstructive shock, which is maybe related to pericardial tamponade or pulmonary embolism. If the contractility is poor, it could be a cardiogenic shock. And if you have ruled all these out, it could be a hypovolemic or a distributive shock. If there is A profile means the lungs are dry, there is no B lines, then these are false responders. So ultrasound has immense applications these days, not only in identifying, but also in guiding our fluid therapy. And serially, we can see where we are. So what is our endpoint? Similarly, we have rush protocol as well, which is again, it tells us about the contractility, about the reserve, and about all the aneurysms and the pipe which is set. So there is, I cannot emphasize that how useful ultrasound is for us. And just to summarize, that FAST protocol, which is focused assessment, ultrasound guided for patients in chest trauma, extended is addition of the thoracic views, and it is highly sensitive, less specific. In unstable patients, definitely it helps us in triage. In stable patients, I would still suggest that we should go to CT to look for all our false negative findings. Thank you. Thank you so much.
Yeah. Hi, Sudhivya. Can you hear me?
Yes.
Yeah, so I would suggest, I think I was more than excited than anyone to be a part of this webinar, essentially because, trauma has been something which has been very dear to me. And from what you said, it was very rightly and very beautifully said. I just would like to, add a few points to consolidate what you said further. So the first thing about chest trauma and ultrasound, the irony lies in the fact that though chest trauma is something that can so very well be diagnosed with ultrasound, but chest trauma is something, especially if it is severe, it is bound to be associated with a subacute emphysema. So it's, you have to take it with a pinch of salt, or I would say a pinch of air, that the same air which can be detected with 100% sensitivity when it is below the pleura, if the same air lies above the pleura, the entire protocol goes for a toss. So that's when we have to keep it in mind that no matter how big a power it is, it has its limitations. Having said that, the most important thing when we are able to interpret images is to have the clinical correlation, which is very vital. As in, I remember an incident wherein, we had a patient with this humerus fracture and rib fractures, and we found that there was fluid on the same side. Other side also there was fluid. We all got excited. We put in bilateral ICDs, and we realized that that patient was a cardiac failure patient and he had fluid all over his body. So we kept on draining his transudate for days together. So in the absence of the right context, it just becomes another modality. So the clinical acumen is something which would always be the primary focus. Now, beyond that, if I were to add a few things, I would say that from what we used to do back in Ganga, where I used to do a lot of trauma, was to extend the application of same ultrasound in everyday practice of those patients. As you rightly said, on day 0, there may not be a difference between a hemothorax and a pleural effusion. But as days pass, the blood becomes more and more hyperechoic. You will be able to understand whether there are loculations, whether there are adhesions, whether this blood is impeding your lung expansion. So that is when you will be able to, realize that now that the blood is increasing, do I need to drain it or not? In fact, one of the very common things that we used to do with ultrasound back in the day in the hospital is you just make a patient take deep breath and see whether the lung is expanding. You make him do an incentive spirometry and see whether the lung is expanding. And that will give you an idea whether effective recruitment is happening or not. You give a patient a block, make him take a deep breath. Is the diaphragmatic exertion good enough? Is the lung expanding to your NIV? Those are the things which help you really in a long way to prognosticate a patient, to know whether you need to tap a fluid, whether your NIV is helping or not. So that's something which is very, very vital, which has been, translated right from the ED to the trauma ICU in a day-to-day practice. And that's something which can be done very effectively. In fact, one of the very nice objective ways of giving a block and making a statement that the block is working is to actually see that diaphragmatic excursion. To make that incentive spirometry and record that excursion. It gives a really good objectivity if you actually want to do a study out of it. And the last point I think I would like to say, I mean, that's just coming straight from the heart more than anything, is as the first speaker had suggested, that there was a Turkish study which had 4,000 chest injuries. So I just wanted to say that those 4,000 patients took them 10 years. If you were to do the same thing in India, just the 10 hospitals we are a part of right now can give those 4,000 patients in a year. So we as Indians really, should go out there. The trauma, the quality of patients, the quality of patient management that we actually do, whether I had seen it in PGI or at Ganga or KM or anywhere else in India, has actually been very, very much on par or more so with what I have been seeing right now in the West, even at the best of the colleges like Adam Brooks. The only place where we lack is to project it effectively what we are doing. And that is when I feel, whether it is ultrasound, whether it is these regional blocks, we just need to go out there, make a statement, do a study, and put it across. So I would say that in any which ways, if you feel, or any one of you guys feel that we really need to go ahead, make a plan, do a study, coordinate together, and form a trauma registry, I think that is something I would really, really like all of you guys to do. Is there any question or anything that anyone else wants to add?
There are no questions as such, ma'am. It has been a wonderful discussion. Anything, any inputs from your side, Dr. Naveen Paliwal, sir, please?
Thank you, Dr. Gaurav. Sorry, Vishal. Definitely, that was a very informative talk from Dr. Sudhivya, and very well addition was there from Dr. Sweta. One thing which I would like to add is, why don't we incorporate this fast or e-fast in pre-hospital settings? Is there any issue with this? This will even give us more time to manage patient and even more effectively.
Can I just make a comment about this? I think if you ask me, I have been following the trauma network pathway very closely in India since as I was working in Ganga for 5 years. Honestly, we are still at a very nascent stage wherein most of the patients that we receive are barely accompanied by doctors. Forget about qualified doctors. So, from what I see over here, every time a patient comes, he arrives in a helicopter and there is a HEMS doctor accompanying. So it becomes easier to incorporate that setup of doing a pre-hospital fast in these kind of patients back in UK, wherein there is a qualified anesthetist or ED person who is actually going on site to receive a patient. In India, at least till the time I have been working, and that's not been too long, almost a year or two back, it's still a CMO kind of a person, or most of the time a nursing staff which accompanies a patient or is there on site. So for them to interpret, at least from what I had experienced in South India, it was slightly difficult.
What we can do is we can just send the images to the trauma center, and there an expert can review those images and then accordingly.
I think that's a good.
Can I respond to Dr. Naveen's query?
Yes, sir, sure.
Yeah, in India, the PCPNDT Act doesn't allow a mobile ultrasound machine. The machine has to be stationed somewhere. So imagine if we imagine that ultrasound machine will go to the trauma area, and in ambulance the ultrasound will be done, the whole law will have to be changed, because the law doesn't allow us to do the sonography in this mobile van. So there is no question, at least as of now.
Sure, I agree. Yeah.
I think just definitely this is the future, and I think the government is working towards it. But at this preliminary stage, because I have also dialed 112 a couple of times, we are still looking at a very long delay. And any patient, even if it's my known patient, anybody would rather take an Uber than an ambulance to the hospital. So the pre-hospital care, it all starts from the site of trauma till the hospital, which I think there's still a long way to go in that. Even if we can educate people enough to raise the alarm, to transport a patient in an immobilized way, I think that still is a step forward. But I feel ultrasound at trauma site, maybe it'll take some time.
Thank you very much, ma'am. It was indeed a great discussion from you, Dr. Shweta, Dr. Sudhivya, Dr. Naveen Paliwal, and Dr. Pradeep Bhatia, sir. Thank you very much, sir. We move on to the next topic, and that is the pain management in chest trauma, and that would be the speaker is Dr. Dipinder, and the chairpersons are Dr. Sanjeev Palta, sir, and Dr. Geetika Duggal, ma'am.
Hello, are you able to hear me?
Yes, ma'am.
Okay.
I'm able to hear you. Just give me a second, please. Dr. Geetika Duggal, ma'am, she's professor and head of the Department of Anesthesia and Critical Care, Medical College, Agroha. Her area of interest is critical care and obstetrics anesthesia. Dr. Sanjeev Palta, sir, he's professor at Department of Anesthesia and Critical Care in GMC, Chandigarh. Sir's area of interest is regional anesthesia, critical care, and pain management. Dr. Sanjeev Palta, sir, can you please welcome and introduce our next speaker, Dr. Dipinder, sir?
Hi. Yes, thank you very much, Dr. Vishal. This is my privilege to introduce Dr. Dipinder. And Dr. Dipinder is professor from the Department of Anesthesia and Critical Care, SHKM, Government Medical College, New. And her area of interest is pain medicine and regional anesthesia. Dr. Dipinder, we are more than eager to know about the pain management in chest trauma. Thank you very much.
Over to you, Dr. Dipinder. Please share your screen.
Yeah, sure. Are you able to see my screen?
Screen is
yes, ma'am.
Please put it into the screen sharing mode. Slides screen sharing. Yes. Yes. Please go ahead.
Okay, thank you so much. So my sincere thanks to organizing team, Dr. Naveen Malhotra sir, my mentor and my teacher, and my dear friend Dr. Vishal for giving me the opportunity to present on this esteemed forum on the pain management in rib fracture, I want to say chest trauma. So in the next few slides, we are going to see that how we can medicate the cage, that how we are going to give the pain relief to a patient. So long live RSSP Society. And so what are the thoracic trauma patients? So we see in the thoracic trauma, it is 25% of the trauma worldwide is the thoracic trauma. And as our previous speaker, Dr. Pooja has already told that 67% of the thoracic trauma cases, they constitute the rib fracture. And we have seen that mortality and the morbidity of the blunt chest trauma, it increases with age as well as the number of the rib fracture. So as we all know that in the primary survey of the chest trauma patients, we need to take care of the life-threatening conditions and they should be immediately investigated and treated. We all agree with this. So based upon the previous data that the thoracic trauma patient or in the case of rib fracture patient, we see that the rib fracture mortality and the morbidity is directly related to the number of the rib fractures and the age of the patient in addition to underlying conditions. So based on this, we have a rib fracture score which counts the breaks into the sides plus age factor. So we score the 1 for unilateral fracture and 2 for the bilateral fracture. The age is factored into the equation because it increases the risk of complication, and we have categorized into 0 to 4. And whenever we find the score is more than 7, it really requires the involvement of acute pain services. So patient of the rib fracture. So we see the patient of the rib fracture. It can be a case of polytrauma, which is coming to the ICU, or it can be in the emergency department. Patient is having head injury, or it may be the abdominal injury along with chest injury. The patient may need ICU admission, or it can be a patient of fall, elderly patient who had a history of fall and patient is having rib fracture. So in both the conditions, we need to manage the pain, and this is the high priority area. So when we talk about when we need to manage the rib fracture pain, so we should know that most common rib fractures, they are 7 to 10 rib fractures. And we see that fracture of the first and second ribs, they are really rare, but whenever they happens, it is associated with the serious damage to the brachial plexus or vessels. And as Dr. Indrani ma'am has already told us that the presence of the bilateral fracture along with lung parenchymal injury, these are the 2 risk factors which causes the pulmonary complication requiring the patient critical care admission and high mortality in the elderly patient. So now I think there are the 2 queries or 2 questions which comes that why we are talking about the pain management in trauma patient. Because in the primary survey, I don't find A, B, C, D in protocols. I don't find any P. But I think when we think if the patient of rib fracture, you are not giving the pain relief, then what will happen? So on average, each person, it breathes about 20,000 times a day. So if you are not giving pain relief to a patient of rib fracture, you can understand the situation of the patient, how difficult it is for the patient to breathe with pain. So this is the status that is समझ नहीं आ रहा कि दर्द में जिंदगी है या जिंदगी में दर्द. It is not about any आशिक status, Instagram status. Rather, this is the statement of a patient with broken rib. So ultimately, I think we all agree, and my previous speakers, they have really put a great emphasis on the fact that pain is important and it is vital to be managed, right? And pain remains the pain remains the most prevalent complaint in the trauma patient. But somehow we have seen in the studies, even it is the most prevalent complaint, but still it is the most underreported complaint. So even if we are not addressing the pain complaint of the trauma patient, somehow the patient misunderstood the physician, as physician is indifferent to the patient. So oligoanalgesia, it is quite common in the injured patient in the pre-hospital and the emergency medicine. So ultimately, by adequate pain control in the chest trauma patient, it is sometimes the most basic and the best treatment you can give to your patient. So as we see that after the ABCD, it is the P. So definitely after the end of successful resuscitation and the beginning of the any post interventions, here comes the role of pain management. And definitely we have the protocol like this only. We have previous speakers talking about the trauma management, and now we are talking about the pain management. So chest trauma, it ultimately leads to respiratory failure, and we have number of reasons that why the patient of chest trauma, they had respiratory failure. Among these reasons, one of the very important reason is the rib fracture. So ultimately the rib fracture, this leads to the splinting of the thorax. Patient is not able to breathe deeply. It leads to hypoventilation, accumulation of secretions. Patient is not able to participate in the physiotherapy, and ultimately patients land up into the pulmonary complication. So by giving the best pain, good pain relief, you can give the best treatment to your patient. Just a minute, my screen is, just a minute. Yeah. So for this, now we all agree that we have to manage the rib fracture pain, and we have too many choices, but yes, definitely we are short of evidences. So we will see that whenever we are thinking about pain relief, multimodal analgesia, yes, definitely it has a very important role. The basic concept is that you want to give pain relief to your patient, right? By working at the different receptors, by working on the pain pathways at the different level, so that all the medicines or all the injections which you are giving, whether opioids or NSAIDs, like they should have a synergistic action. So when we are talking about the multimodal analgesia, and if we don't talk about the regional anesthesia, it is incomplete without it. The reason is that the regional analgesia, it offers a plethora of benefits in the patient with multiple rib fracture, both in terms of minimal side effect and very profound good pain relief effect. So when we are talking about the regional analgesia, we have thoracic epidural, we are putting thoracic paravertebral and intercostal blocks previously. And now the new plane, they are new blocks which have made their way, that is the facial plane blocks. So over the recent years, we have seen that these facial plane blocks, they have burgeoned in number as well as the popularity. So in the next few slides, we will see that why we are going for these blocks. First of all, we talk about the epidural analgesia, and we all know that epidural analgesia is the gold standard we are using for the bilateral rib fracture from so many years. And we really see that when the patient is having pain relief, the epidural analgesia, it is really worth, because patient is having decreased number of pulmonary complications. So we have very good number of studies in favor of epidural analgesia. So there are technical considerations when we are giving the thoracic epidurals, like from upper thorax, the angulation is little less, but in the mid thorax, the angulation of the spinous process is quite, so you need to go through the interlaminar space a little bit higher. And similarly in the lower thorax, it is a little less angulations. So these are the technicalities of this epidural block, which we are giving previously as well. So we have the first choice definitely was the epidural, and we have number of studies in favor of epidural analgesia, that it is going to improve the outcome in patients with multiple rib fractures. And when we talk about the outcome, it can be in terms of decreased hospital stay, it can be decreased number of ventilator days, and it can be good pain relief. Patient is able to walk, patient is able to go back home. So this is the, just a minute. I'm not able to see the first line of my slide. Just a minute.
It's epidural analgesia for severe chest trauma and analysis of current practice on the efficacy and safety.
Oh, thank you. So epidural analgesia, definitely, there are the studies which have shown us, we have number of studies in favor, but at the same time, there are the studies which have shown that in the trauma populations, we see 30% exclusion criteria for the epidural patients. So these are the exclusion criteria, because we see as life expectancy is increasing, we have elderly population, they are coming with rib fracture or polytrauma, and they are on anticoagulation medication. So these are the risk factors, these are the population which should be excluded from the thoracic epidural. Or there are other conditions. In polytrauma patient, you will see the patient is having hemodynamic instability. So these kind of the patient, they need some other interventions rather than going for thoracic epidural. So even if we agree that thoracic epidural is good enough for the pain management, but 30% of the population if having the exclusion criteria, and if you have some other modality, then it is better for the patient to rather than putting them on the risk of bleeding. So definitely we all agree that it is not the best modality, but it is the best studied modality till now. So after this thoracic epidural, then comes the role of thoracic paravertebral space. And we have seen the thoracic paravertebral block is the most appropriate evolutionary choice after we talk about the epidural. So with thoracic paravertebral, we are blocking both the dorsal and the ventral rami in the paravertebral space. Here you can see in this slide. Just in this slide, you can see this is the wedge-shaped paravertebral space, and this is bounded by the vertebral body and intervertebral disc. And this is laterally, it is bounded by the parietal pleura, and posteriorly it is bounded by the transverse process and superior posterior transverse ligament. So anyway, previously we were doing the landmark technique, and now we are using the ultrasound to enter into the thoracic epidural paravertebral space. And we really appreciate the patient is having very good segmental, sensory and sympathetic block, and good pain relief is achieved. The beauty is that it is easy to perform. It produces a less sympathetic block. It doesn't causes the urinary retention, and this also allows for the unimpeded neurological assessment. So these are the technique. We can put our probe in the transverse plane or paramedian. I have given this patient a paravertebral block of chest in a rib fracture patient. And this is my transverse technique, and ultimately very good pain relief is really satisfactory for the patient as well as for the treating physician. So this is the study about the comparison between the thoracic paravertebral and the epidural analgesia, and they have found the comparable results. So it is very good technique in all those conditions where you find that the thoracic epidural can be challenging or it can be risky. So intercostal nerve block. I think previously in my remote memories, whenever we are talking about the rib fracture, I used to think about the intercostal nerve block, because intercostal nerve is carrying the pain sensation, and if we block this nerve, it is going to very good pain relief. And this is really a very good modality. And with the use of ultrasound, we are really enjoying if we are giving the intercostal nerve block. But the problem is that it needs to give the multiple injections, right? So it is good injection technique, but it needs multiple injections, and chances of the systemic absorption are very high. But again, this blocks we are giving with ultrasound guided techniques, and we really enjoy if the patient is having 1 or 2 rib fractures, you can give these blocks and patient is having good pain relief. So as we see that we are evolving our techniques from landmark based to peripheral nerve stimulator, and now we are using the ultrasound guided. So here, when we are talking about the tissue plane blocks, we see that these are the different modalities. So these facial plane blocks, myofascial plane blocks, or tissue plane blocks, they are the different modalities as compared to previous techniques, even with the ultrasound. So we have seen in the operation theater, we are giving day in, day out the ultrasound guided injections either in the ICU or in the case of OT. So we are always trying to approach the nerve. We are trying to put our probe in the close proximity to the nerve, and we are targeting the nerve. But in case of facial plane blocks, what happens? We are not directly targeting the nerves. We are giving in the 2 planes, either it can be the muscle or it can be the facial plane, and we are injecting local anesthetic over the planes, and then we see the sensory blockade, right? So when we talk about the tissue plane blocks, I remind this poem. It is very old English poem, which says that something old, something new, something borrowed, and something blue. So what is old? Something old. Why it has been said? We all see that it is nothing new. If we talk about the tissue plane blocks, we have to go through the old anatomy books. We have to go through the old anatomy text if we really want to learn the technique, right? Something new, yes, we are using the ultrasound, and it is really helpful for us to putting this block. Something borrowed, we have borrowed from our surgeon friends who are dissecting along the tissue planes. And something blue, yes, methylene blue dye is very frequently used for tracing the nerve, or for uptake of the nerve by the methylene blue. So this is the way this poem applies for our tissue plane blocks. So why do we need these myofascial plane blocks or these tissue plane blocks? Yes, they're potentially effective. They are much easier and safer. They causes less side effect. We have seen the greater cranial caudal spread with the use of fluoroscopy as well. And they also give us the opportunity for the continuous catheter in some conditions, right? So I think the most driving force was that if we want to give the chest block, it was the desire to find a very suitable and safer alternative to the paravertebral or epidural block, but with similar efficacy. So here the similar efficacy is still debatable, because we need more and more studies, right? As Dr. Shweta has already told, that we don't have much data related to Indian context. So we should come up with more and more studies about the efficacy of these blocks, because we don't know that how long this drug which we have injected is going to stay in the facial plane in which we are injecting, right? So basically the mechanism of action, which is not very much clear, but we assume that this blocks, they act by the conduction blockade of sensory efferent. And when local anesthetic, it spreads within the facial plane of injection to reach the nerves which are running between the plane. And ultimately it also diffuses into the adjacent muscle layer. And it also acts upon the peripheral nociceptors as well. So this is an article in which the mechanism of the action has been explained by comparing it with the sniper rifle or shotgun. And they have seen that when you inject your local anesthetic in the defined facial plane, but not close to all the nerve structures that you would like to block, and you will see there is a random but favorable spread of local anesthetic. And you can compare it with the shotgun in the hope that at least one of the pellets will hit the clay trap. So now we have understood what about all these facial plane blocks. And when we are talking about the chest trauma patient, so we are talking about the chest wall blocks. To understand the anatomy, so anatomy is very important if you really want to understand how you can give the chest wall blocks. So in my previous time, when I started giving the chest wall blocks, I used to see at the YouTube, and I try to see the ultrasound images, and then I try to create the same images in my patient by putting the probe in the same plane, and somehow getting very good results and happy with that. But the problem is that after some time it goes off from my memory, and again I have to say the same video to put the same block. So I think rather than this, what approach should be done, that we should go through the anatomical images thoroughly. And if we can understand the chest wall anatomy in a proper way, it is very easy for us to remember the technique. Then we need not to go through whether I have to keep the probe laterally or parasagittal or transverse, we need not to remember. So in the next few slides, I will try to see that how we can enhance our anatomical knowledge to give these blocks. So this is the chest wall. We divide the chest wall into 3 parts. So between the sternum and the mid-clavicular line, this is the anterior medial chest wall, right? So between the mid-clavicular line and this posterior axillary line, here is the mid-clavicular line, and the posterior axillary line, it is the anterior lateral chest wall. So this anterior chest wall, it is divided into anterior medial and anterior lateral between the mid-clavicular line. So between the posterior axillary line and your spinous process is the posterior chest wall. So we have divided the chest wall into anterior medial, anterior lateral, and posterior chest wall. So going through the anatomy, this is the thoracic musculature. This is the anterior lateral from mid-clavicular line to posterior axillary line. We see serratus anterior, latissimus dorsi, and the pectoralis major muscle, which is present in the anterior medial as well as the anterior lateral part. So another very important muscle is the transverse thoracic muscle. So this muscle is present in the anterior medial part in addition to external and intercostal muscles. So this muscle is basically attaching the sternum to the ribs. So in the anterior lateral chest wall, when we are giving the blocks, we are basically seeing the serratus anterior and the latissimus dorsi along with the pec muscles. And here we see the transverse thoracic muscles. So this is the posterior chest wall. You see the anatomy of the posterior chest wall musculature. Above the this T7 spinous process, there is a most superficial muscle layer is the trapezius. And below this is the latissimus dorsi, right? So second layer is the rhomboides between the T3 to T7 or between the spine of the scapula and your scapula. You see the rhomboides major and the minor muscle, and very deep to it, you see the erector spinae muscle. So this muscle group is really very important when we are going for the chest wall analgesia, that too in the case of patient with pain which is localized to the posterior chest wall or whole of the hemithorax. So this erector spinae muscle group is actually a combination of 3 muscles. So in the most medial side, we have the spinalis, and then we have the longissimus thoracic, and then we have the iliocostalis lumborum. So what is the significance of understanding the basic anatomy about all this? That below the spinalis muscle, which is very close to your vertebral body or spine, very close to your spine, you see there is another ligamentous structure present below the spinalis muscle, which is known as spinalis ligament. So whenever you are injecting your drug in the erector spiny plane or into the paravertebral space, so we see the craniocaudal spread because of the presence of this ligamentous structure below the erector spiny muscle. So now come I think the most beautiful part of the thoracic anatomy is the course of spinal nerve or intercostal nerve. And if we can really appreciate this course, it is really going to help us for putting the blocks. So here I'm just going through the details little bit about the spinal nerve. So after coming out from the intervertebral foramen, the spinal nerve, which is here you can see the DRG, and this is the ventral root. It is coming, spinal nerve, it is coming out and it is dividing into the dorsal ramus as well as the ventral ramus. So here we see the dorsal ramus, it is supplying the erector spiny and the teres major muscle and this trapezius muscles. So as we see this ventral part of this spinal nerve, this is the dorsal ramus and this is the ventral ramus. So this ventral ramus, it is traveling along the inferior border of the corresponding rib, and this is the intercostal group along with the vessels, and this is the name which is given to the intercostal nerve. So you can see this intercostal nerve, it is traveling between the three muscle area here. It is traveling between the internal intercostal and the innermost intercostal muscle. So whenever we are giving our intercostal nerve block at any level, either at the level of the lateral chest wall or at the level of the anterior, we are giving the injection between the innermost intercostal muscle as well as the intercostal muscle, right? So here you see what happens here, that as this nerve, intercostal nerve, it is approaching till the sternum and it is giving the anterior cutaneous branch over here, you will see this innermost intercostal muscle, it transitions to form the transverse thoracic muscle, which I have shown you in the anterior medial part of the thorax. So now we are giving the block here only. Now we are giving the block between the transverse thoracic muscle and intercostal muscle. So in the lateral chest wall, we see that this nerve is traveling. This is the intercostal nerve traveling between these two muscles. And here you see close to the mid-axillary line, it is giving the lateral cutaneous nerve. And this lateral cutaneous nerve is going just above the serratus anterior muscle. So when you are giving you want to block the lateral cutaneous nerve of branches of the intercostal nerve, you are giving either the superficial serratus anterior or you can go the deep serratus anterior nerve block. So these are the pectoralis major and the minor muscle. You are giving your block here only. And you will see, you can see in this beautiful slide, whenever you are giving your block in the superficial serratus anterior, it is equivalent to your putting your block in the pec 2 in the same plane. So ultimately these planes, they are in continuations. But the problem is that if you are giving close to the target, then you will achieve the maximum effect over here only, because we don't want that how much it is going to spread cranially or caudally. So this is the reason we have different approaches to target the different area. And if you broadly divide from this slide, you can broadly divide the chest wall as I already divided into the anterolateral and the posterolateral. So if I draw a line like this only, this is the posterior chest wall and this is all about the anterolateral and anteromedial chest wall. So this is all about the anatomy of the chest wall. Now it is very easy for us to understand all the blocks. So here we are giving the paravertebral, where we can give the dorsal ramus and the ventral ramus. Now it is the intercostal nerve. This intercostal nerve is traveling between the two muscles, innermost and the internal intercostal muscle. Here it is the serratus anterior, and here you already know about the transverse thoracic muscle, where it is giving the anterior cutaneous branch. So this is all about how you can give the facial plane blocks. Your needle, you have put your needles for the PEC 1, PEC 2 for serratus anterior, and I will go little details into as well. So these are the anterolateral chest wall. First one is the PEC 1 and PEC 2. You are putting your probe along the deltopectoral groove, and you can see this muscle layer. With the very good ultrasound machine, you can see the 3 layers of intercostal muscle as well. So this is the serratus anterior plane block. Again, it is the same muscle. You are seeing that this is a latissimus dorsi. Here it is a tapering edge. This latissimus dorsi is tapering over this wall, and serratus anterior is the muscle which is basically present on the ribs as the muscular slips, right? So as you put your probe posteriorly, you will see the size of the serratus anterior muscle will increase. So you can identify this muscle and you can give either superficial or you can give deep. So the basically advantage of giving the superficial nerve block is that the thoracodorsal nerve, it lies over this plane as well. So you are giving the good pain relief if you are putting the superficial pain block. So another mechanism of the action which has been documented in the serratus anterior plane block, in addition to the routine mechanism, that is, it is a diffusion of the local anesthetic. So whenever you are putting this deep serratus anterior plane block, your local anesthetic, it diffuses to the external intercostal muscle over this space. So this external intercostal muscle, it really helps in the deep breathing, deep inspiration. So if this nerve is blocked, the patient will be able to breathe without any pain. So this gives a very good result in rib fracture patients. Definitely we need more studies in favor of this mechanism of action of serratus anterior plane block. So this is the technique which has been used in patients for the critically ill patient, and you really want to wean off the difficult cases. The pain relief is very important in such case scenarios. So these are the few slides of serratus anterior, superficial or deep. You can give both kind of the blocks, or you can give the one kind. Gradually you will understand that how I need to. You can give this serratus anterior plane block in this supine position. So this was a patient not able to turn the position, not able to sit down. So I have given the serratus anterior plane block in the supine position when patient was comfortable and patient was having the posterior rib fracture. So after that, I had given the erector spiny plane block for the better relief. So now we are coming to the anterior medial chest wall. These blocks are very rarely used. Mostly they have their place in case of cardiac surgery, where you are working close to the sternum, and this is the area which you give the analgesia. Very rarely you will see the anterior fracture of the ribs. One of my patient, I have seen the anterior fracture of the ribs, and this blocks really works well. To understand that how we can give this block, it is very easy that we have three muscle layer. First of all, we have the pectoralis major, then I have the internal intercostal. Now, I know that close to the sternum, this innermost intercostal muscle, it transitions to form the transverse thoracic muscle. So my plane of injection, it can be between the pectoralis major or the internal intercostal muscle, or it can be between these two muscles. So depending upon, I think as we go up in the skill, we try to put our needle down, right? So initially we can give on this plane as well, but as you, with experience or with your learning curve, as you're going up in the skill, you can go up to the deeper side. Yes, definitely. So very important to learn about the posterior chest wall blocks. And another term which has been given to the posterior chest wall blocks is the paravertebral by proxy. The idea is that you are not entering into the paravertebral space. Here, this is the paravertebral space. So you are not directly putting your needle crossing the superior costotransverse ligament to enter into the paravertebral space. Rather, you are working around it, but still it causes a similar effect. So we have erector spiny plane block, we have the retrolamellar block, and we have the midpoint transverse process to pleura. So this is the block somewhere between the transverse process and pleura midpoint. So this is known as a midpoint transverse process block. It is the lamina, and this is the tip of transverse process. So if you are approaching up to the tip of the transverse process, it is the erector spiny block. If you are going up to the touching the lamina, it is a retrolaminar block. So as we are working in the pain specialties or pain management, you always find that the bone is basically your friend, right? So in the retrolaminar block, you're touching the bone, you are just withdrawing the needles and giving and see the separation of this muscle, erector spiny group of muscle, right? So here it is the erector spiny plane group. You can see the separation of this fascia from the transverse. And here it is a paraspinal intercostal muscle. It is similar to the intercostal muscle, but you are giving close to the paraspinal region. So all these blocks, there is a term that is the paravertebral by proxy. So this is a study which is comparing the erector spiny plane block versus the retrolaminar block, and they have seen the spread in the
Dr. Dipinder, are you there? I think maybe we have lost, she has lost the internet connection.
Wait, I think.
Dr. Sanjeev Palta sir and Dr. Geetika Dugal ma'am.
Yeah, I think we should contact to Dipinder if she's continuing.
I am calling her, ma'am. In the meantime, ma'am, I think we can start with the discussion, sir. What do you say, Dr. Palta, sir?
So my idea is that although she has extensively covered about the blocks over there, but very important thing which I have done in my practice is the kind of adjuvant which has to be given. And many a times I have seen that I've been more more well versed with giving SAM block in the chest trauma patients, and we are adding tramadol. And the biggest advantage is, rather than going in for a continuous block, giving 50 milligram of tramadol with the local anesthetic provides an analgesia for approximately 48 hours. That is, I would say, wherever you have the facility of ultrasound available. But the next best thing, which I see in my department also, that I'm very fond of using morphine in an epidural space. And giving a single shot of 3 to 4.5 milligram. In fact, I give 3 milligram only, 3 milligram morphine to a patient. It provides an everlasting analgesia, approximately going to some 12 to 16, 17 hours. I don't require an infusion pump. I do not require any kind of other things. And what happens is I put the responsibility on a resident who is coming to the night duty, so that he or she can evaluate the patient again and can give the 3 milligram kind of this thing to the patient. Now, in all those centers where they do not have patient-controlled analgesia systems, they do not have good infusion pump system, I still feel, we should talk about the adjuvants. We should talk about the morphine as an alternative, which will obviate the need for giving continuous infusions. We should talk about tramadol also. And my personal choice is always SAM block with tramadol. And like we were talking in the last lecture, that it is not possible to take the ultrasound machine to other places, but at least in a hospital setup, in-house setup, when you have an emergency over there, one can have an ultrasound machine, especially for all these trauma cases, which can easily take care of fast also, as well as thoracic traumas, and can help the anesthesiologist also to provide these kind of pain relieving blocks. Over to my co-chairperson, please.
I fully agree with you, sir. I think in the chest trauma, analgesia, providing analgesia is a therapeutic, because it improves all the lung functions and also improves the patient's efficacy. And so it has a therapeutic effect. And I fully agree that using opioids while giving these blocks as an additive, that has a long lasting effect in this. And about the visceral pain, now the facial pain block, because we are discussing, it can be used with the patient, even those who are on the anticoagulants. One of the study has shown that even the patient is on enoxaparin, they are using these facial pain blocks.
Pain block.
Yeah. So, and the limitations of the epidural block, like when the patient is an injury, chest injury, there's a hypotension, the risk of hypotension and other is quite high. And even when we are giving these blocks, we need proper positioning, and painful is also always painful.
You're absolutely right, madam.
The patient
and one more thing is there, once you are in an ICU managing a patient on ventilator of flail chest, if you provide a good interfacial pain block or even an epidural morphine, it leads to very early, ventilatory free days. You can extubate the patient very early, because it is a pain only, which is, just making him to catch the breath, not able to breathe properly, and retention of secretions. Once that part is taken care by anesthesiologist, the patient is able to be extubated early and then continue with the same pain management also in ICU.
It is Dipinder is back now.
Dr. Dipinder has joined back. Dr. Dipinder, can you hear? I think she still has some glitches.
Even we have different modalities of providing analgesia. I think we should see the strengths and weaknesses of these modalities and weigh as per the requirement of the patients.
Absolutely right.
The setup we are using it.
My idea is only that not every center is so well rich and well equipped with all kind of things. So where you do not have infusion pumps, where you do not have a patient-controlled analgesia, going with a simple epidural catheter, providing adjuvants like morphine, provides a very long-lasting analgesia to the patient, and it is very, very economical, particularly for third world countries like us.
In USG facility is not available at every level.
It's not available everywhere.
Dr. Deepinder, can you hear?
Yeah, now I can hear. I have joined from the phone, not able to join again.
Doesn't matter. We have a discussion going on between Dr. Sanjeev Palta sir and Dr. Geetika Dugal ma'am regarding the opioids in as adjuvants in the blocks.
Yeah. So what I have gone through the literature that we are adding dexmedetomidine as well as the dexamethasone in these now blocks, and we are trying to enhance the effect of analgesia, and we're trying to prolong the duration of analgesia as well. But the problem is that we do not have much literature in favor of it. For definitely, this is the area of future research. So, but we are I am adding the dexamethasone in my blocks patient for giving the long duration analgesia.
Dr. Deepinder, what is your experience with opioids, particularly morphine or semi-opiates like tramadol? Have you ever used them as an adjuvants in these blocks?
Sir, I have used dexmedetomidine and the dexamethasone for my facial pain blocks. I'm not used the opioids for these blocks, sir.
Okay, and what about the epidural morphine?
So epidural morphine is good. I'm not using the epidural morphine. Okay. So we are using the facial. So, so basically in our hospital, we have started a rib fracture protocol. So whenever the patient is coming in the emergency department, so we have a performer, and the performer is filled by the treating CMO on duty, and we have trained them to assess the patient of rib fracture, and the patient who really need the pain interventions, they are being referred. And I'm really trying to compare the two techniques, sir, the erector spiny plane block and the serratus anterior. So absolutely. I have seen that, sir, I have seen that the rib fracture patient, they have associated lung injury. The patient is coming with the pneumothorax, and in the recovery phase, sometimes patient is already admitted in the surgery ward, and the patient is not able to discharge because patient is having very severe pain. So in such patient, I have seen a very beautiful effect of serratus anterior plane block if the patient is recovering well and the chest tube is in C2. Sometimes patients, they don't breathe deep because of the pain of chest tube or discomfort because of this. So serratus anterior is really good. But in case of a posterior rib fracture, what I feel that erector spiny plane block is a better option. Serratus anterior help us to position the patient. So sometimes we can combine the two techniques and then we can have the good effect as well.
I agree with you, but if you ask me, if I come to know my resident is giving erector spiny block, I'm much more relaxed rather than going to know that my resident is going to give ultrasound guided paravertebral block. Because I also feel erector spiny is one of the most easiest and complication-free block for the posterior fractures.
What your experience about catheter placement in these facial pains?
Yes, ma'am. Like in my setup, what I did, I started giving erector spiny, but what I felt that there was few patients who not having very good effect. There was minimal effect, and that was short lasting. So in those patients, I started rechecking what I have injected in which plane. So I injected along with contrast, and I checked in the fluoro as well. So this was just to basically be the more accurate, be the more precise for this technique. And what I've seen that you can give the epidural catheter, you can put the epidural catheter in the this erector spiny plane block. But I try to give along with this contrast to make sure that it is not moving in other plane as well. So sometimes I think this ultrasound and fluoro, they both can combine to give the better results. And initially, you are not pretty sure that how much drug you are injecting and how it is spreading cranially, caudally, and how many segments. So like if you are injecting 20 ml to 40 ml, somewhere close to it. So we don't know whether it is going into the intervertebral foramen and then epidural as well. So in two patients, I have injected with contrast in around 10 to 15 patients. And in 10 to 50 patients, I have seen the two patients having the epidural spread as well. So somewhere we need to be, we definitely, I think I was similarly, as Dr. Shweta told you, I was same planning that we should have a multi-center study just to see that how the block for which we are talking so much about, that is the erector spiny plane block, we really need to see that how much effect we achieve if we do the continuous analgesia with the help of catheter. And another issue is, ma'am, setup issue is another issue. So you need a very close monitoring. You need a close monitoring at the end of the resident doctors or other people who are working around you. So sometimes you are a bit afraid that rather than any complications, I should be safe.
But
This is a condition which is inhibiting you.
But usually these patients have other injuries also and bilateral injuries also. So when you are giving block, you have to go for the multimodal analgesia. I think this is a gold standard for multimodal analgesia. We cannot do only with the facial plane blocks and PFP.
Yes, sir. They should be combined with other modalities as well. And since they sometimes give you the rescue analgesia and all those patients where you feel the epidural or paravertebral can be risky.
Yeah, but respiratory parameters improve with these blocks.
And ma'am, I'm very sorry for this presentation. I couldn't complete it.
We have Dr.
Can I
Sushila
just add
Takshak.
one more point?
Sure, ma'am, please.
Actually, the pre-COVID area, we were having shortage of syringe pumps, in the trauma intensive care. So we used to use the Baxter elastomeric pumps.
Yes, ma'am.
So
Yes.
in those places where, you don't have syringe pumps, for all these blocks, if you want to give it as a continuous thing, these elastomeric pumps come very handy.
Yeah, ma'am, you are right. I have put the demand, but we are not getting right now.
But they're quite cheap also and comfortable for the patient to carry, and they can move.
Yeah, right. It's mobile. I mean, they make them mobile.
Yeah, they are very, very handy.
There's one hands up from Dr. Sushila Takshak, ma'am. Dr. Sushila
Yeah.
Takshak. Welcome.
Hi, good
Very
evening.
good evening, ma'am. Good to see you,
Good
ma'am.
evening, everyone.
Please go ahead,
I
ma'am.
just want to add that when we don't have an ultrasound and we want to do a serratus anterior plane block, we've done, just feel for the surface of the rib and go hit on the rib and just come back a millimeter and inject your drug. That works beautifully. And if you check with the ultrasound, we have seen that it spreads like we were doing it with ultrasound.
Wonderful,
So-
ma'am. Wonderful. Have you published it also, ma'am? Or is it a known fact?
No, it's few articles I've seen have come up, and our study we are going to publish soon.
Oh, that's the Takshak technique.
No, not
Definitely.
In the RSSCP conference in 2019, we put a paper where we had done few cases.
Right.
So,
right.
right.
That's great.
Okay.
Good, ma'am.
Goodbye.
It's nice, ma'am.
Ma'am, it's, I would like to correct you, ma'am. It's RSSCP, not RSSCP, ma'am.
Can I just add a point or two, if you don't mind? I'm sorry, I know we are short of time.
Please, ma'am.
One of the things was, as sir rightly said, even we had observed back in Ganga that DEXA works wonderfully well in extending the duration of the block. And after the first day of block, the patient used to be so happy that the next day he used to be more than ready to take a block. So that used to bypass the complete complications and the learning curve of catheters altogether, because first 2 or 3 days, if the pain is taken care of, patients are usually okay. But the irony of the situation is, the other day when I was working with one of my colleagues who is from Ireland, and I just said that we can just give a DEXA if we are not able to put in a catheter. And he had no clue that things like these exist. And I must have myself given over 100 blocks like these. But the fact that because it was not there on a paper, like the way you said, tramadol, I very well believe it can extend it to 48 hours duration. But the fact is, all the good work that we do, we never bother to put it out there objectively. And that's why, despite of, I had combined experience of more than 5 consultants over there together, simply because of our volumes. But I couldn't really justify myself because I couldn't produce a paper which says so. Though I had seen 100.
My case report is published and I'll send it. I'll definitely send it.
Please do. I'll be more than happy. So I would suggest all of you should get together. I mean, let me know if you want to combine it with the South India as well. And let's do a proper multicentric trials in
Absolutely. I'm game for
and
it.
just one last thing from my side is, if you're concerned about the learning curves, especially in blocks like paravertebral, serratus, which is rightfully so, what we have a practice is, whenever a patient has an ICD for whatever reasons, we go for these blocks like paravertebral or maybe a blind serratus in case, just to make life easier for us and the juniors, because an ICD is already in place, and improve their learning curve. And the ones which we feel that ICD is not there and things like that, we just go for the plain blocks like erector spinal, where the chances of needle puncturing the pleura is less.
That's nice.
So
Nice.
probably that's the thing, which we can do. Yeah. Thanks.
Thank you very much.
Thank you, ma'am.
Thank you very much. Thank you very much. I think it's all done, ma'am. From with your due permission, Dr. Indrani, ma'am, should we extend the vote of thanks and thanks everybody, ma'am? Thank you very much, ma'am. Everything was discussed in detail, and it would be my profound privilege to propose my vote of thanks to our valued and distinguished dignitaries on this platform. Firstly, I would like to extend my thanks to President Dr. Indrani ma'am for always being a support and giving webinar a wonderful discussion. I would also like to thank Dr. Tej K. Kaul sir, our patron, for joining us, and we always learn a lot from you, sir. I would also like to thank our chairpersons in this webinar who gave their valuable critical inputs on the talks delivered today. The wonderful speakers for giving it a so meaningful discussion, and it was a academic extravaganza today. I would also like to thank our President-elect Dr. Naveen Malhotra sir and Dr. Sethi sir for constantly pushing us to maintain the high standards of this society. Thanks all for such an interactive session. It was a pleasure listening to you, and thank you everybody. We have Dr. Naveen Malhotra sir. Sorry for the interruption. We have Naveen Malhotra sir. He wants to say something. Dr. Naveen Malhotra sir, please, sir.
I was saying just congratulations.
Thank you very much. Thank you. It was a pleasure for me listening for me. Thank you very much, sir.
Thank you.
RSSCP and Dr. Sanjeev Palta, sir.
No, thanks a lot. Thank you very much. I said long live RSSCP.
Good night, sir, and long live RSSCP.
Fantastic webinar, and thank you very, very much.
Thank you, ma'am.
Long live RSSCP.
Long live RSSCP, ma'am. It's good to have you back, ma'am, Dr. Ma'am.
Thank you.